and NAVLE, and they love to test your understanding of the grading system, the exact surgical corrections required, and concurrent joint pathologies. Let's break down exactly what you need to know to capture every point on this topic. Pathophysiology and signalment. Patellar luxation is primarily a developmental disorder involving the misalignment of the quadriceps extensor mechanism, quadriceps muscle, patella, patellar tendon, and tibial tuberosity. Medial patellar luxation, MPL, represents 75 to 90% of all cases. Classically seen in small and toy breeds, Yorkshire Terriers, Pomeranians, Chihuahuas, it typically causes a genuvarum, bow-legged stance. Board trick. While LPL is more recognized in large breeds, MPL is still the most common form of luxation in large breeds as well. Lateral patellar luxation, LPL, less common but typically seen in large and giant breeds, Great Danes, St. Bernards, Irish Wolfhounds. It typically causes a genuvalgum, knock-kneed, stance. Clinical presentation. The classic presentation is an intermittent, non-weight-bearing, skipping lameness. The owner will describe the dog running, pulling the hind limb up for a few strides, and then putting it back down and running normally. This happens because the lameness is mechanical rather than strictly pain-driven. When the patella pops out of the trochlear groove, the stifle cannot extend properly. The grading system, high yield, you must have the Putnam 1-to-4 grading scale memorized perfectly. Board questions will describe a physical exam finding and ask you to select the grade or the appropriate treatment. Grade. Physical exam findings. Clinical signs. Grade 1. Patella can be manually luxated but return spontaneously when released. Usually asymptomatic, an incidental finding. Grade 2. Patella luxates spontaneously with flexion/extension. It remains luxated until manually reduced or the dog extends and derotates the joint. Frequent skipping lameness. Mild bone deformities may begin to appear. Grade 3. Patella is luxated most of the time but can be manually reduced into the groove. Persistent lameness, notable bone deformities, shallow trochlear groove. Grade 4. Patella is permanently luxated and cannot be manually reduced. Severe lameness, crouched gait. Extreme skeletal deformity, trochlear groove may be convex. Diagnosis and crucial concurrent issues. Diagnosis is made via palpation, start at the tibial tuberosity, and work proximally up the patellar ligament to the patella. Radiographs are necessary to evaluate the degree of skeletal deformity, femoral bowing, tibial torsion, and to check for secondary osteoarthritis. The golden rule for the stifle. Always check the cranial cruciate ligament, CCL. Up to 15 to 20% of dogs with chronic MPL will develop a concurrent CCL rupture. The chronic internal rotation of the tibia, due to the medially displaced extensor mechanism, places excessive continuous stress on the CCL until it tears. If a dog with a known skipping MPL suddenly develops an acute continuous lameness, suspect a CCL rupture. Surgical management, conservative management, weight control, NSAIDs, joint supplements, and physical rehabilitation is generally reserved for asymptomatic grade 1 cases or mild grade 2 cases in older dogs. For symptomatic grade 2 and all grade 3 and 4 luxations, surgery is indicated. The goal is to realign the extensor mechanism. You need to know both the bone and soft tissue procedures. 1. Bone reconstructions. Trochleoplasty, block or wedge recession, deepens the trochlear groove. Wedge and block recessions are preferred over simple abrasion arthroplasty because they preserve the vital articular hyaline cartilage. Tibial tuberosity transposition, TTT. The tibial tuberosity is cut and moved laterally for MPL or medially for LPL and pinned in place. This physically realigns the pull of the quadriceps mechanism. Femoral/tibial osteotomies, reserved for severe grade 3 or grade 4 cases where there is extreme bowing of the long bones. 2. Soft tissue reconstructions, usually done alongside bone procedures. Release. The contracted tissues on the side of the luxation are released, e.g., medial retinacular release for MPL. Imbrication. The stretched tissues on the opposite side are tightened, sutured, e.g., lateral imbrication for MPL. Key insight for the exam. A soft tissue only repair is almost never the correct answer for a clinical case. Board questions will look for a combination of a bone procedure, like a TTT, and trochlear wedge recession, combined with soft tissue release/imbrication. Test my knowledge on this.